Hello, this is Dr. George Jacinto talking with you today about assessment, diagnosis, and treatment in clinical social work practice. I've noted that when assignments ask that students complete a biopsychosocial assessment, diagnosis, and treatment plan, the results range from confusion to treating clients for a symptom or two without a diagnosis indicated. We will discuss the assessment process that uses a variety of documents and information. Often we may read over the material that has been submitted to us with a referral. There are two ways to approach this process. After reading confusing material from past records in my own practice, I decided to see the client and move through the process without paying attention initially to the other assessments. In this case, I would establish rapport with the client and then have the client talk with me about themselves, historically from birth maybe to the present, or however they might want to share the information. And their story will offer many clues and twists in their journey through life. As I hear their story, I begin to collect symptoms and other crystals of information that will help me with the diagnosis. I list all of the possible symptoms and diagnostic criteria that may be found in the DSM, and then I begin to group together associated symptoms that may meet criteria for particular diagnosis. I refer to the DSM to note if the cluster of elements I've listed meet the required number of criteria to meet a particular diagnosis. This process is what I refer to as building a rationale for your diagnosis. You can't just simply say someone has major depression. You must first answer what criteria in the listing for the disorder one has. In criterion A, for instance, of major depressive disorder, you would need to have at least 5 or more of the symptoms present to diagnose the disorder. Be sure to indicate the ICD-10-CM codes when you diagnose. This is the billing code used by agencies or in your practice. In this case, you would list F32.1, major depressive disorder, moderate, as an example. Once you've determined the diagnosis, you will move to treatment planning. You can treat clients if you can't treat clients, if you do not have a diagnosis. So what are the predominant issues with the client that can benefit from treatment? So these are the kinds of reflections you want in terms of providing some sort of treatment suggestions. And from this you will develop goals and objectives for treatment. And I'll share an example of this later in this video. Next, I want to say a little bit about the antecedent activity to assessment, which I call building rapport with the client. Rapport building is a critical piece of your work with clients. If you don't first establish the rapport, you're not going to get a lot of useful information in your work with the client. I've developed an acronym, having attempted to reflect on this rapport building idea for some time, which I call WELCOME, the WELCOME approach. So basically, W has to do with welcoming the client into the environment that you have provided for them in your office setting. So you want a safe and comfortable environment as a client enters your practice space, where you welcome them in. And note how you welcome the client into your office as well. Do you shake their hand? Do you point to the chair? Do you stand up when they come in? In other words, try to figure out what seems to best bring comfort and security to your clients as they come into your space. And then next you're going to engage the client. So that's the E part of this process. You want to provide a warm environment as you ask the client to share his or her story with you. L is one of the most critical components of this process. This is where you want to totally focus on listening to the client intently and hearing what both is being said verbally and non-verbally. A lot of times our clients have been seen by people in the past who quickly make decisions about what the client's diagnosis is and move them along. You want to give the client a sense that they're the most important person in the world at the time that they're with you, and you want to very carefully hear what they have to say. So C, the communication or piece of this, is to communicate your caring presence, that you really are concerned about what their issues are and how you might be able to help them. This can be found in how you attend to the client thoughtfully and respond to the client's questions. O is here, the O is for observe key behaviors and messages that the client may be sharing with you. And also notice posture, the nature of the story, listen to key words in the story that the client may use metaphorically. How is the client describing their situation, and what kinds of non-physical or non-verbal cues do you know? So you're looking for physical cues. Does the client look around while they're talking to you? What are you seeing the client do? M is the chance for you at the end of this process to merge key ideas and weave details about the client into a coherent report that you will provide the biopsychosocial spiritual assessment for in this case. And then E would be to explore key ideas in the subsequent assessment that you're working on, which will link to the diagnostic exploration that you will do a little later in the process. This welcome process is the result of what Dr. Scott Miller calls deliberate practice. I want to spend a moment to talk about deliberate practice because I think it's an important element of what we would do in our own practice with clients. Dr. Scott Miller asserts that deliberate practice was the most important element to improve clients' skills. So he defines practice as when the therapist engages the client during the therapy session. So that's what practice is. But in this case, deliberate practice he defines as the preparation the therapist makes when not in the therapy session. So this deliberate practice is not when you're in the session, but between sessions, in which you may reflect on your work with the client and what you may do next, planning the session so that you're addressing the client's needs, and practicing therapy skills or learning new techniques that you might utilize with clients. Once rapport has been established and the client feels comfortable in your office environment, you'll move to the assessment phase of your work. Note here I've indicated that Dr. Miller has a website and is associated with the Center for Clinical Excellence. I suggest that you might want to follow up and read some more information about deliberate practice and the work that he does. Then moving into the assessment, the most critical phase in your work with the client is the assessment, because this is where you move into the territory where you collect a lot of material that begins to make sense out of the client's story. There are a wide assortment of assessment tools and forms used in agencies and private practice settings. It is important that when we engage in assessment, we keep in mind the strengths and the person and environment perspectives of social work in all of your work. Always have that as kind of in the background there as you're collecting the information. Your attentive listening can net you rich material as you move toward diagnosis and treatment planning. You'll want to make sure that you explore in some depth the biological elements of the client's life. Here you will discuss physical health issues and concerns regarding the client's ability to function. Next, you will want to understand the client's current psychological situation. You may explore past mental health treatment and life events that may have affected the client's psychological functioning. The mental status exam is important in revealing a series of issues that may affect functioning, such as cognitive deficits that may be experienced by the client, or even psychotic features. So you want to explore widely what's going on and carefully attend to what the mental status material is that's coming forth. The social area of life includes the client's family, friends, and interactions that are experienced in the environment in which the client lives and functions. Another area of concern is that of spirituality. This does not just mean a religious affiliation and participation. It may be a spiritual focus of a person who is either not religious or involved in religious activity. In a real sense, this area explores the client's understanding of his or her purpose in life and the meaning of life to the person. Here you may want to explore a list of symptoms or diagnostic criteria without a specific notion to the diagnosis after you've collected the biopsychosocial spiritual material. As part of your work towards a diagnosis, you will either look at the case records, as I mentioned, prior to seeing the client, or waiting and reviewing them after, considering the medical and mental health diagnoses before and after you tentatively decide what is the correct diagnosis. Remember in your work to discuss what medications the client is taking and supplements or vitamins they are using as well. Also, what illicit drugs or other substances the client is using. Many times vitamins or supplements may be potentially toxic with certain prescribed medications. I want to discuss briefly Maslow's hierarchy, since it may provide a lens upon which to view the client in context. So here we have the hierarchy, which we are all familiar with, but I think it's helpful to attend to it in terms of looking at client needs. I remember when working in VR and other settings, often people are given all sorts of appointments they need to keep, and while not having transportation as an issue. So keep in mind what's going on in the client's world as you begin to plan what it is that the client might be needing to do. Note in the biological and physiological needs listed here, if people aren't having sufficient food or nutrition and a place to live, certainly no shelter, and this can be very debilitating. So pay attention to these, because unless you begin to address the lower needs as you move up the hierarchy, the prognosis or tendency for success of the client may be greatly compromised. Attend to finding a way for the client to meet these needs and is crucial to functioning at the next level and successfully transitioning out of whatever the treatment regime is what you're looking at. Certainly finding a place to live and a sense of security is important. But it's important to note, too, that we have clients who live in very precarious places in which they may be at risk for harm based on the environment. So that's a very important piece, not only in the assessment, but when looking at what you're going to provide in the way of treatment. If you're putting the person in an environment where the treatment may work for a while, but you're returning them to an environment in which their friends and associates that engage in activities are not pro-social and may be risky, that long-term success may not be realistic. So be careful in terms of your planning about how you're going to address those kinds of issues. Be careful to explore these needs with the client so that your picture of helping them might be realistic and more complete. So the client should always be involved in the treatment planning if at all possible. So, what do you do in terms of people who have grossly compromised life situations in terms of where they live? For instance, if they're homeless, what do you do about that? And then, of course, as you move up the level, you look at belongingness and love needs. And again, when you have children that have been kicked out of their homes by their parents, that may be a major focus of their experience at a particular time, because they may not trust anybody. And how do you begin to address that again for them and in your planning and treatment ideas? So keep in mind the needs of the client as you begin to develop the plan, and most importantly, include the client as much as you can in the planning process. Next, we will move to diagnosis. I'm going to use one diagnosis as the example in this video, although obviously our clients do not usually have just one diagnosis, but here I've given you an indicator of what the one is that we'll be using. Again, remember to use the ICD-10 CM codes when you label diagnoses. So here we have the F10.20, which would be alcohol use disorder severe, would be what we would use as an example here. And then we'll talk about developing a clear rationale for diagnosis and citing the criteria to fit the diagnosis. So with the assessment written up, you are now ready to develop a diagnosis. Make sure that when you list your diagnosis, you can use the ICD-10 CM code followed by the diagnostic label as I just shown you. I'm going to use this one diagnosis, as I mentioned, as the example. The DSM tells us that this sort of diagnosis may have a comorbid diagnosis of bipolar I disorder, in terms of there's a high likelihood people with bipolar I may also have alcohol abuse, because it's a way to medicate their symptoms. When they're manic, they may want to be more depressed or balanced, so they would take a depressant as an example. Figure out whether or not the diagnosis is correct by carefully examining the diagnostic criteria and client's symptoms to be sure that the material you found in the mental status exam is included as part of this. You want to make sure that the elements of the mental status exam are really a big part of what you're doing in terms of reaching the diagnosis. The DSM will tell you how many of each criteria you will need to match the diagnosis that you're considering. This is what I mean when I suggest grouping and clustering symptoms as you're working with the client. As you get all the symptoms clustered, then you begin to see which ones are associated with each other and how they might fit a particular diagnostic label. Also keep in mind recent life events that may impact the client. When I ask for a clear rationale, I mean that you should be able to cite the exact criteria the client meets for the diagnosis you've selected and that they've met the correct or exceeded the number for that particular label. You must be able to defend a diagnosis by indicating what exact criteria are met in the listing. Remember, as you plan, you need to keep in mind the strengths and person and environment perspective. A quick review again of the steps taken to render a diagnosis here. Again, you collect and assess data and trying to determine the reliability of the data, but always, keeping in mind the strengths perspective as well as the person and environment perspective so that nothing gets missed in the long term. And then the differential diagnosis and resolution of uncertainty. So when you have a number of symptoms that seem to closely match several diagnoses, you need to then begin, as I said, to parse it out by counting the diagnoses that fit the diagnostic label that you're looking at. In this case, the diagnostic label was the the alcohol use, and so this client met 7 of the criteria we see here in criterion A, 1, 2, 3, 4, 7, 10, and 11. So again, formulating the diagnosis includes 2 principles, and this is important to keep in mind. The first one is that of parsimony, using the single most elegant, economical, and efficient diagnosis that meets the client's symptoms. In this case, we're looking at the alcohol use disorder severe. And then, of course, the hierarchy of mental disorders exists and tend to decline in severity, which we'll look at shortly, because that has a lot to do with how you begin to set up goals and objectives for your treatment plan. And then, of course, in the long term, what is the prognosis for the client? In other words, what are etiology, what are the causal factors? And then describing the various diagnoses and what the prognosis would be. For instance, if someone is psychotic, what is the prognosis for that person given their age and history around that? That would be an example. So looking at the hierarchy of mental disorders, you want to begin to address in your plan, beginning at the top of this listing and moving down in terms of priority of what needs to be done first. Alcohol use disorder severe suggests a physiological sort of dependency that one might look at, which could be construed as a medical kind of issue that the person is experiencing. So I've placed that at the top there. Now, if you have a mood disorder, you first want to get the person clean before you can begin to deal with the symptoms in that level. So, if it's depression or anxiety, as you go down the listing, it talks about, if you look at the bottom there, the least of the disorders in terms of working, in terms of effort perhaps, would be adjustment disorder or no mental disorder, which in most cases you wouldn't be treating. So again, you will determine the symptoms first, and then the client experiences, for instance, in this case, tolerance and withdrawal. So this suggests that there's a medical kind of component to this. And you would want to address abstinence, as I said, first, and then begin to deal with other issues that the client is experiencing. Your planning goals and objectives, you would address each diagnosis in the logical order that fits the kind of treatment and symptoms experienced by the client. Again, keeping in mind the hierarchy of diagnoses here will help you in developing an effective and elegant plan. Next, we move to treatment planning. And again, do not treat a person unless you have a clear diagnosis to provide a rationale for the treatment, because if you treat without a rationale or a diagnosis, it doesn't make sense. So think logically about this. And the planning phase would include developing goals, objectives, which we will discuss here. This exercise is brief, however, you may want to target dates for completion of objectives as part of your treatment plan. In this case, we are going to discuss F10.20, alcohol use disorder severe. The DSM states that for the specifier of severity, this client would need 6 or more symptoms in criterion A. In this case, we have 7 symptoms, as you see over here. Requires larger amounts of alcohol for it to have a similar effect over a long period of time. Desire and unsuccessful attempts to control usage. Much time spent obtaining and using and recovering from the experience, having a craving for alcohol, missing work or other important social aspects of life, and then importantly we have tolerance and withdrawal. Here increased amounts are needed to get intoxicated as desired, and then there are withdrawal symptoms that the client may experience. Next, we have, we have 3 goals that the client, we're going to work with the client on, that we've talked with the client about and are set forth in terms of the objectives. First, we're looking at abstinence from harmful and hazardous drinking, which is a major problem currently. Medical assessment, and introduce new coping skills and or build on existing coping skills. So those would be the goals for this particular treatment plan. And again, looking at objectives and interventions. This comes from the DSM-5 in Action, Dr. Sofia Jingaleski's book under alcohol use disorder in the text. But I wanted to give you sort of a brief look at what this might appear to be when you render it. So the first objective here is to evaluate amount and type of alcohol consumption and intake. So on the intervention side, the client would report during drinking patterns what's going on with them in terms of feeling, and verbalize beliefs about drinking. Then provide education to client regarding drinking patterns, use, and consequences. So this could be kind of a part of the coping element of looking at reasons for drinking and consequences. Encouraging the client to collect or connect beliefs and consequences to increase awareness, use, and patterns, and then assist the client in problem-solving strategies to reduce harmful use. So as part of that, you want to look at elements of coping, and then reduce factors linked to use. So again, encourage the client to report behaviors that risk clients' well-being and occupational status, so if they're missing work. Encourage clients to verbalize thoughts, feelings, and emotions in response to risk factors due to the use of alcohol. Provide education to the client regarding drinking patterns, use, and consequences. Again, it's similar to one of the others because these kind of overlap. Assist the client in developing problem-solving strategies to reduce risk behaviors and ameliorate consequences. And then establish a support system to use during recovery. Again, develop with client a list of friends and family members who provide support, particularly if they're part of AA. That's an important support group. Contact friends and relatives and ask for input on the client's substance use. Contact these people and attempt to meet or speak with them about the importance of recovery for the client. So the client, yourself, and friends could be interacting with each other there based on the client's permission. And then a physical exam by a physician. Again, refer the client to a physician for an evaluation. That's a very critical element of working with the client, because over time a long time use of alcohol can affect a number of body systems, and so it's important to assess where the client is health-wise as well. The results of your thoughtful work will enhance the client's lives. Moving them toward a positive future, as we see here, looking toward the future, I think is important as opposed to looking to the past. And again, strengths are what we want to enfold within the objectives and interventions that we do with clients, citing strengths as opposed to deficits, perhaps. I hope this has been helpful, and I can be reached at either of the email addresses here at the bottom of the slide. Thank you.